Hi guys, it's Jody again. Now we're going to talk about heart failure treatments, and these are really treatments for cardiomyopathy as well. If somebody gets to a point with cardiomyopathy that they start to need these treatments. So the first one we're going to talk about is biventricular pacemaker. So you guys already viewed the presentation. We already discussed pacemakers. But this one is different. This biventricular one is really a treatment for heart failure. Somebody is not going to get a biventricular pacemaker unless they have heart failure. So you'll have people that get pacemakers that have conduction issues, but the contractility in the heart muscle is just fine. So this is really when that heart muscle is damaged and the heart needs more of a kick, more of a stimulus to try and contract that muscle to pump more blood. So what does it do? Instead of pacing just the one ventricle and having the one lead into the ventricle, it actually has two leads. So it paces both the right and the left ventricle. So it really treats symptoms of heart failure for clients with moderate to severe heart failure. So they have to have a reduced ejection fraction. So usually you won't see a biventricular pacer unless the client's ejection fraction is, say, less than like 30%. And it may also include that ICD to be able to shock the patient if the patient has dysrhythmias. So once that heart muscle is weakened and there's damage to the heart, there can be risk for dysrhythmias as well. So they may require the biventricular pacer with the ICD. So biventricular pacing is also called cardiac resynchronization therapy. There are two pacer spikes before the QRS complex. So if you see this, this is your QRS. You can barely see a P, right? So these pace rhythms sometimes look a little funky. And sometimes these pacer spikes are so close together that you can barely determine that there are two pacer spikes. But you can see it really well on this strip. So it's pacing both the right and the left ventricle and then stimulating that, that muscle to contract. So you get that QRS. So nursing care, so activity restrictions, it's going to be very much the same post-operative care or post-procedure care that you would have for pacemakers. So no heavy lifting for several weeks. Do not raise that affected arm above shoulder level. Again, they might be given that arm sling. That arm sling is just a reminder not to lift their shoulder. They do not have to wear that arm sling. They should report the dizziness, weakness, fainting, because it could be that it's not pacing appropriately or generating enough of a cardiac output. And then hiccuping, it could be stimulating the diaphragm. So those are things that the client would want to notify the provider of. Avoid injury to the pacemaker site, avoid strong magnets. It could set off security detectors, notify provider of signs and symptoms of infection. So remember, that's redness, swelling, drainage coming out of that incision, fever, any of those things. And that they should learn to check their pulse. And that's very difficult for some patients. So some patients will actually buy like a pulse oximeter to look at their pulse. But basically, we just want to make sure that whatever the pacer is set at, that heart is beating at that set rate if it is a fixed rate pacer, which usually the biventricular pacers are. So then we talk about ventricular assist device. A lot of times I will call this an LVAD or a left ventricular assist device. They also have right ventricular assist device, but the more common is the left ventricular. So I tend to always say LVAD because really any that I've seen in practice have all been left ventricular assist device. But it's an implantable mechanical pump. And what it is done is it's used most frequently for left ventricular, again, but can be right, and it could be a BiVAD doing both sides. But the reasons for the VAD are three. So it's either bridge to transplant. So the patient is unstable. They really need a heart transplant. So they need this put in temporarily until they can get them to transplant. It's also destination therapy now. So it could be that the client is not a candidate for a heart transplant due to age, due to underlying conditions, whatever, but they need some more support. So they will put a VAD in. And then it could be temporary if they have temporary heart failure. So sometimes you'll have patients with like a pregnancy-induced cardiomyopathy or Takotsubo or something like that where they could have recovery from the heart failure, so they could temporarily put something in to support the patient. So right now they actually have total implantable VADs, I believe, and I haven't seen those in practice, so I don't know that we're doing those, but I'll have to look to see if I can find some literature on those. But the ones that you'll see out like for home care, or you could have patients coming into the hospital with other issues and maybe they have an LVAD, and if it was placed in the last 5 to 10 years, it's probably going to look like this. So what it is you have the pump in here that's actually supporting that left ventricle and pumping the blood. And because it's continuous, you get this continuous flow of blood. You won't hear a heartbeat, so you don't hear a lub-dub. You'll hear a whirring of just the circulation going on in here. And then it has to attach to a battery pack, right? Something has to make that pump work. So the ones that are on the outside, they will have this drive line that comes down and out their side and then attaches to this pack. And then these are the battery packs. So you really want to assess for infection at this drive line site, if that's what they have. So the benefits are basically just that it helps pump the blood from the ventricles to the rest of the body. It's giving them cardiac output, adequate cardiac output, because their heart muscle is very weak and it can't do it on its own. Risk factors, big risk factors. Infection is huge, especially infection at that driveline site. So, I took care of a patient who was getting an LVAD as a bridge to transplant. And the patient ended up with such a horrific infection at the driveline site that they were on IV antibiotics for a very long time, and it really was impacting their ability to get a transplant. So the infections can be really bad. Pump malfunction. Now these pumps work very, very well, so they shouldn't have issues with pump malfunction, but it is a device, just like anything, right? You could have malfunction there. Bleeding, a huge risk. They need to be on warfarin, because remember, this is an artificial device that we've now put in the body. The body is going to react. So very, very high risk for clotting. So they will be on warfarin and having their blood checked quite frequently. So definitely all of the teaching has to be done that goes along with warfarin and the risk for bleeding. And then there's right-sided heart failure. So if they have an LVAD that's pumping the left side, we could be supporting that left ventricle, but the right side can weaken. They can end up with right heart failure. And again, blood clots, so which is why they have to be on warfarin, which gives them the bleeding risk. So pre-procedure, if they were going to have this done, and really you are only going to take care of these clients pre-procedure if you're working on a heart failure unit. I believe at Strong it's 734 still. I know it was when I worked there. It was 734. So and I believe Rochester Regional is doing them now too. But so you would do advanced directives discussion, right? Do they have their advanced directives, confirmed support system, right? We want somebody to help them out because this is huge. When they go home with a left ventricular assist device, they need somebody to support them with the care of that device, right? And somebody that knows how to charge the batteries and disconnect the pump from the batteries and making sure everything is at home is adequate and having that adequate support person. Again, informs consent that you just basically have to make sure that they signed it and that they really do understand, and the doctor come in and explain to you the risks and the benefits. Any diagnostic testing, you would want to make sure that that was done, do teaching on that, and then begin teaching on VAD management. So on the heart failure unit at Strong, and if I keep deferring to Strong, I'm sorry, it's just because I worked on that sister unit there. We took care of a lot of heart failure patients. I worked on the cardiac step-down unit. So we saw some of their patients if there were overflow from the heart failure unit. So you need to begin the teaching for VAD management. On the unit at Strong, they have really a team that will help educate these patients. When they started first doing the VADs, they actually had people going to the client's home, educating the clients. Like if they had like say I live in Scottsville, we have a Scottsville Fire Department and emergency services. Somebody would go to those emergency services and provide education to them because they want they want the people to know that are going to be going to that client's home in the event of an emergency that that patient has a VAD, because we don't want to just start compressions. Things are a little bit different with these patients if you're providing emergency care. But I don't think they do that anymore. I took care of a client. I had to go out to see him, and he was all the way out near like Watkins Glen, and he came home on Thanksgiving, and the hospital just provided him with a DVD to give to his local healthcare providers and emergency workers. So, they're not doing that formal education anymore. And a lot of it is because these have been around now. So, it could be that people have seen them, but there's a lot of teaching that goes on, a lot of teaching about the driveline care. That's huge. They also look at the pump and they record numbers. They check their temperature. So there's a lot of management that they do at home that the nurse would begin teaching in the hospital. Of course, you would do the medication teaching on the warfarin. They might be on an antibiotic. You're going to refer to home care services. So as far as the VAD management, it's plugging in equipment and charging batteries. And we tell the clients we don't want them to have to rely on power, like a generator type power that's not continuous flow of electricity. So they really have to be plugged into a solid outlet. They want to document their readings from their pump, and you guys don't have to go into the specifics of the readings, and I'm not going to go into those with you because it is something that you would not need to memorize, because if you ever had to take care of one of these clients, you would get that information. Driveline care. So the big thing with the driveline care is it's going to be a sterile dressing, and the clients will learn to do that on their own. They will learn to do that sterile dressing, but you would be doing that in the hospital, and you would be teaching that driveline care, teaching on follow-up of MD appointments, blood draws for their warfarin, so their PTINR, ensure the number to the heart failure team is available. So they should have that right on the refrigerator, available at all times. Of course, any signs or symptoms of infection, any signs or symptoms of heart failure, and when and who to call for concerns. So collaborative care, you have a lot of people involved and clients that have a VAD. So you have the primary care physician, the cardiologist, the heart failure team, the surgeon, if they're going to have any other kind of surgeries, home care, nurses, physical therapies, occupational therapies, could have social work in. Very often you have social work in because these are expensive devices. They need to make sure that they have transportation for blood work, all of this stuff when they go home. So there's a lot of people involved. So communication is really key. And when you have these clients, heart failure team kind of takes over and they say anything with the VAD is going to go to the heart failure team. They're not going to expect that the primary care physician or the cardiologist really deal with that. It is specific to the heart failure team, and their cardiologist will likely be within that heart failure team. So then we talk about heart transplant. So heart transplant is only going to be for end-stage heart disease, must wait for a donor heart, right? VAD may be necessary to bridge them to transplant. So if you have a client who's really sick, really needs a heart transplant, and they're very unstable, they may need to have that VAD placed to get them to the point where they can then get a transplant. When they have that VAD, we want to make sure they don't get an infection and that everything is okay so that they can get to that transplant when that heart is available. Immunosuppressive drugs will be used to prevent rejection after the heart is transplanted. We must consider eligibility. Are they eligible for a heart? Okay, these aren't like kidneys and livers, which tend to be more abundant for transplant. And it needs to occur within hours of organ removal from the donor organ to remain stable. So eligibility, so we consider who is a candidate. Usually it's less than 69 years of age, end-stage heart failure with a prognosis of less than 1 year. No infection or other significant health problems. So like I said, if you have the VAD in waiting for the transplant and your driveline gets infected, then you have to wait until that infection clears. It's terrible. Psychologically stable, and you have to understand the risks and benefits. Healthy weight, so they need to have that healthy BMI, no smoking or alcohol for 3 months, and an adequate support system. So who is not appropriate? If they're advanced age, if they're 89 years old, I'm not saying that they won't do it if a client is 70 years old, so that's why I put usually it's less than 69, but they have to look at that age. Are we going to put this heart transplant in to somebody who only has probably a few more years anyway, but their prognosis is less than a year, with the heart failure. So they really have to look at that. There's a lot of ethical things when you think about transplant. If they have another medical condition that could shorten life, so if they have a cancer, or if they are, in full on kidney failure, they have other things that are going on that are going to shorten their life, they're likely not going to get a heart transplant. If they have an active infection, they will not get one if they have a recent personal medical history of cancer. So if you have somebody who had breast cancer when they were 30 and now they're 60 and they haven't had any issues with breast cancer, that shouldn't affect their eligibility. But if you have somebody with a recent cancer, that would definitely affect their eligibility. And you also have to look at those clients who are unwilling to make necessary lifestyle changes. So if they don't want to stop smoking, they don't want to stop drinking, they don't want to change their diet, they don't want to reduce their BMI, then are they really going to be compliant with taking their warfarin and caring for their LVAD? So they really have to look at that. We want a really good candidate that's going to have a very good outcome with the transplant. So risk-associated rejection, primary graft failure, so the donor heart just doesn't function, and that's the most common cause of death in the first few months after transplant. Thickening and hardening of the coronary arteries, infection, side effects from the immunosuppressant therapy, which could include cancer. Okay. So nursing care, we want to assess for bleeding, assess chest tube drainage. This is post-surgery. So they just come out of surgery after transplant. So initially they would go to the ICU and then to the heart failure floor. I believe they're taking them post-transplant too. So they'll assess for chest tube drainage. Obviously they'll be on telemetry. We gradually warm the client due to hypothermia, which is induced during surgery. And then we assess for signs and symptoms of an infection. We assess for signs and symptoms of rejection, which would be flu-like symptoms, so shortness of breath, blood pressure changes, irregular heart rhythm. Those could all be signs of rejection. So again, collaborative care, a lot of people involved with these clients, so communication is key. We don't want to overwhelm the client, so we try to make it as easy as we can with people providing care. I can tell you, I'll just go back here for a minute, being in home care and taking care of clients with VADS and with heart transplant. Just in home care, you'll have the home care nurse who is generally is the case manager of that case. And with home care, you may have a social worker going to the patient's home to visit. You can have a physical therapist going to the patient's home to visit. You can have an occupational therapist going to that home to visit. And you can have the lab going to the home to do blood work a couple times a week. And then you could also additionally have a home health aide that's going in and assisting with personal care. How overwhelming do you think that is when you have all of those people coming into the home? And if all of those people are coming into the home and telling the patient the same thing every time they go in, like providing the same teaching, or it gets overwhelming for the patient. So when I would manage these clients, I would only go when I'd have to go. And I would try to combine my visits. So say if physical therapy really had to go in and do this, I might try to go in right as right before the therapist was getting there to do my stuff, to kind of just not overwhelm with a bunch of people coming at all different times of the day. So, I mean, you work with the patient, but that is something you have to think about when you see these clients. And really, it's clients that have all sorts of problems with lots of people involved, is that if you have everybody going in, all these people seeing the patient, they're all telling them the same thing, or God forbid, they're telling them contradicting things. It's so overwhelming for clients. It really is overwhelming. So the communication between the providers is key, so that you can organize schedules, not overwhelm with the patient with the same information, be on the same page so that you're all working together. It's so important. And that's all I have really on treatment. So we can talk a little bit more in class. And of course, as always, just bring your questions and we will go over everything for you if you are unsure of something. Okay? Thanks.